honored to be invited to be here with you today. And how many of you in the audience have that mid-afternoon mind fog? Okay, right. Well, unfortunately, Randy's a tough act to follow. And I don't think I'm going to be quite as entertaining as he is to help you with that fog, but I'll do the best I can. So I was asked to talk about managing distress and depression in MS. So many people ask, does MS itself increase distress? And yes, there's very good evidence that exacerbations increase distress. How many of you have ever had an exacerbation and not felt distressed at all about it? I don't see any hands. Right. Disease progression. There is some evidence for a relationship that distress increases with disease progression, and there's no evidence that any of the treatments for MS increase the risk of significant depression. It used to be thought that some of the early medicines were associated with significant depression, but the evidence for that has faded. I want to talk about the types of mood disorders that one can have. And these mood disorders can happen to anybody, not just people in MS. There are adjustment disorders in which we're just having a temporary difficulty adjusting to a new condition, maybe a new level of disability, maybe a change in our lives or in our MS, and we're distressed about it or anxious about it for a while, but then we adjust and we're okay. Then there's a type of mood disorder called major depressive disorder, and this is the one that we are most concerned about in MS. When I try to explain major depression to people who've never experienced it, they say to me, well, why don't you just pick up your bootstraps or think happy thoughts or, you know, things like that. And I say, you really don't understand depression. So we will talk a little bit about it. And then there's a type of depression which not only includes depressive episodes when you're sad and hopeless, but when you're over-energized and what they call in a manic state, where your thinking is unclear and your kind of judgment is poor, and that's a bipolar disorder, and that also occurs in MS. And then there's an anxiety disorder. How many in the audience have ever felt anxious for a moment in your lives? Right. We all do. We all feel anxious. And so anxiety is kind of the normal state of being human. However, if it is extreme so that it's really interfering in our ability to enjoy life, then we would call it a disorder. And Dr. Shapiro already talked to you about PBA, pseudobulbar affect, or involuntary expressive emotional disorder, in which you're laughing, but you don't feel funny inside, or you're crying, but you don't feel sad inside, or the laughter and crying is excessive. So anxiety. Anxiety is actually more common than depression in MS. So, and there's very high prevalence rates, maybe 30 to 50% of persons with MS have crossed the threshold of feeling anxious some of the time to having an anxiety disorder. And one of my students, I really don't do any work at the MS Center or in the lab. The students do everything. I just kind of, take credit for a lot of it. But one of my students recently found that anxiety mediates the relationship between processing speed. And although I'm not here to talk about cognition with you, processing speed is the fundamental cognitive issue in MS. How fast those nerve action potentials are traveling through the brain, that kind of determines many of the other mental abilities, like memory is dependent on processing speed. Many other aspects of thinking and cognition are dependent on processing speed. And so my student found that anxiety affects processing speed, and also it mediates, it affects the relationship between this fundamental cognitive process, processing speed, and other cognitive processes like memory. So we have a cog rehab program, so now we switched it up. We make sure, because of this result, that we measure anxiety in people and we treat that, because we know we'll be able to improve their cognition better, if we make sure that that is adequately treated. So, What is major depression? You have a sad mood. How many of you here in the room have ever felt sad? Okay, of course. But if you feel sad most of the day, every day, for a protracted period of time, well, then we call that a depressive-related sadness. And if you lose interest in the things that you're normally interested in, not the things you can't do anymore, but the things that you can do that you're interested in, and all of a sudden you lose interest in it, well, that's a symptom of depression as well. Some patients with depression report, I can't feel pleasure in anything anymore. Fatigue, as Dr. Shapiro talked about, and sleep disturbances, he also mentioned, can also be symptoms of depression as well as symptoms of MS. Social withdrawal, sometimes suicidal thoughts, all of these things are associated with major depression. So we want to make sure that we screen for it, we assess for it, because there are successful treatments for it, and I want to talk to you about some of those successful treatments shortly. So depression is very common in MS. It is more common in multiple sclerosis than in any other central nervous system disease disorder. And so we're wondering about that. As Dr. Schaefer said to you before, MS doesn't, it leaves you with a relatively normal lifespan. But yet some CNS disorders, like ALS, actually cause you to die in a relatively short period of time. Yet in MS, which doesn't kill you, there's more depression. So we've been learning over time that some depression is directly a result of disease processes. There are a number of MRI studies that show particular areas in the brain that are highly associated with depression. And so we now know that part of it is a result of the MS. So that doesn't mean you can't treat it. It doesn't matter if your depression is caused by a brain lesion or by particular genetics or by a bad situation that you're reacting to. It doesn't matter what is causing it. The important point to note is that it can be treated. And with depression, one of the biggest risks for anyone who's depressed in the general population is that if you're really depressed and get more depressed and don't get treatment for it and nobody notices it, well, you can have suicidal thoughts that you can then act out on. So it's very important for you when you go to your neurologist to not just talk about your spasticity and or your sexual issues, important to talk about, but if you're not feeling well emotional, tell your neurologist that. Tell your nurse that so they can assess you and treat you for this symptom. There's a lot of gaps in our knowledge. Randy had mentioned before evidence-based treatment versus practice-based treatment. Well, there's more practice evidence than there is evidence when it comes to anxiety and depressive disorders in MS. So in terms of treatment, I just want to show you my colleagues and I in the lab developing our double-blind, placebo-controlled studies to treat these problems in MS. So I did a literature review prior to coming here today to just ask the question, how many psychiatric treatment studies are there in the literature on multiple sclerosis? And I was not too surprised, but to find that there are very few studies published on the treatment of psychiatric problems in MS. I can only identify 18 studies that utilized medicines or psychotherapy to treat depression or depression and anxiety. Some of them came from our group. And several studies of psychotherapies that have been done that are now adapted to treat other symptoms of MS. So we adapted something called cognitive behavioral therapy, which I'll talk about, to successfully treat sexual dysfunction in MS. And that has been adapted to help improve or lessen fatigue in MS and insomnia in MS. And we recently applied it to treat pain perception in MS. There's also one study out there that wanted to see, can we reduce new brain lesions in MS by teaching the person to stay calm and manage their stress, be in control of their emotions. And the study found that in the first 6 months, this was published in the journal Neurology a couple of years ago, that at 6 months there were fewer new brain lesions in people that were kind of receiving this treatment and practicing it on a daily basis. But at a follow-up a year later, after the study was over, there were no differences. So we're not quite sure what that means, whether it really had an effect or whether it was an artificial effect, or if you have to practice these things every day to maintain some effect. But more research is needed. So there are a number of studies that show antidepressant therapy in MS works. So, so that's one thing. You have a couple of options to get your depression treated MS. You can have antidepressant therapy. Go to your neurologist can prescribe it, a psychiatrist, any physician could prescribe an antidepressant. But there's some particular considerations you should have when you're kind of telling your neurologist you're depressed, and your neurologist or physician thinks, okay, you seem depressed enough that this is an option for you, antidepressant treatment. And it's important for you to tell them whether your sexual function is important to you, because many antidepressants will directly cause sexual dysfunction. There are some that do not. So let your physician know that. Let your physician know if you're particularly anxious or not, because some antidepressants are better for people who are both depressed and anxious, or very anxious alone, and some antidepressants could actually increase depression. So you have to make sure you give your prescriber the full picture of what you are feeling and what is important to you, in terms of your function and in terms of your relationships, so they can prescribe the medicine that'll give you the most benefit and not interfere in other important things in your life. So, and some studies have found that even in patients that are diagnosed with depression, they're not adequately treated. So even when their healthcare team knows that they have a major depression. So what I would ask you all to do is, if you're depressed, make sure you demand getting treated for it, and bring that up, when you go to your next physician visit. So it's important to consider the right kind of antidepressant to give. Also, the right kind of psychotherapy is important to give. And the right kind of psychotherapy, the most important thing about psychotherapy is that you go to a therapist who knows a lot about MS. That's the most important thing, in terms of the practical aspects of getting help. In terms of the evidence, cognitive behavioral psychotherapy, which is a type of psychotherapy that identifies the patterns of thinking and behavior that change with depression. There's more evidence-based for that working, but the evidence is slim. So again, the bottom line is, go to someone who knows a lot about MS and get your psychotherapy from that person. But cognitive behavioral therapy works on changing patterns of thinking and behavior, and when we can change those patterns, the mood disorder significantly lessens. So the idea here is that in depression, we have an overwhelmingly negative view of oneself, other people, the future, and we feel very helpless, sense of failure, incompetence, unlovability. All those kinds of things occur in depression. And anxiety. Anxiety is the feeling that you feel when you expect something's going to happen, and is it going to be good or bad? Your expectation of what's going to happen. You're expecting something's going to happen, and it's going to be bad. I want you to think about that the next time you're anxious. So what are you expecting in the future that's going to be negative? And what we tell our anxious patients is, whoa, 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 come back to the present moment. Because when you're anxious, it feels to you as if the bad thing has already happened. And whatever that bad thing is may not happen. How many of you have ever made a mountain out of a molehill? Kind of been really anxious about something, and then realized a couple days later, why was I so upset about that? We all do that. So I want you to ask yourself the next time you're anxious about something, how important is this event going to be a year from now? Most of the time when I ask my patients that, they say, a year from now? Dr. Foley, I'm not even going to remember this a year from now. So why are you getting so upset about it? So controlling your thought processes, changing your expectations is a critical aspect of helping with both anxiety and depression. We give people diaries when we treat them for depression and anxiety, and these are some examples of thinking that we say is so extreme it's distorted in persons with MS who are depressed. I had one young man who said, I can't play catch with my son, therefore I'm a failure as a father. He was a sports nut. This is what he did. His father, played sports with him. That was their connection. And I said to him, so there's no other way you can be a great father unless you can play sports with your son? And he said, I never thought about that. I said, well, I want you to think about that, because there are many different paths to being a great father. But he was stuck and depressed, and he couldn't change his thinking. And so these are other examples. I can't take care of my children by myself anymore. I need help, therefore I'm a failure. So people overestimate their inabilities. They overestimate the ideas that they're worthless or a failure or things are hopeless when they're depressed. So we want to change that. So years ago, we conducted kind of really the first randomized clinical trial that addressed both anxiety and depression and sought to improve coping with MS. And so basically, the two groups were relatively equivalent on relevant variables. And we found that giving the Beck depression inventory, which is a common measure for depression, that we were able with the CBT group to significantly reduce the depression in the experimental group, significantly reduce state anxiety, that is, how anxious are you today in that group. Not so much on long-term trait anxiety, but the treatment was relatively short. And we were able to increase and enhance their coping abilities as well. So we know, and many studies have replicated this. I'm going to skip over this wonderful slide of Dr. Shapiro's and talk a little bit more about how we work with people using cognitive behavioral therapy. We've applied it to work on people to improve marital communication and intimacy. In terms of comparing, patients frequently ask me, well, what's better? Should I take an antidepressant or should I get this cognitive behavior therapy? And I kind of, ask them if they're very severely depressed, we will want them to get both right away. But if they're moderately depressed, it's a little bit more of a choice. And so there was one study that compared how effective antidepressant therapy to cognitive behavior therapy to another kind of therapy was. And what this study found is that, well, that wasn't the correct button, was it? Okay, this is the correct button. And this study found that a support group did not work that well, but that both antidepressant therapy and this cognitive behavior therapy had very similar effects on reducing depression and MS. So if someone's mildly or moderately depressed, we can ask them, well, you can take a pill, here are the side effects, or you can try the CBT, the cognitive behavior therapy. And if someone's seriously depressed, we want them to do both. Okay, so in terms of making the decisions about what to do, well, it's not something that the doctor or the psychologist just says. It's a result of a communication and a relationship and kind of a joint decision on how you're going to approach this. We even found that treating depression over the telephone works using CBT, significantly reduces depression. And this is becoming an importantly increasing approach to using telehealth for improving depression in MS. Because how many of you find it easy to get to the clinic every week? I don't see one hand. Would you rather just kind of, get services at home and have them be effective? How many hands? Of course. So, so this is going to be the wave of the future for treatments for depression in MS. So Psychotherapists that know MS know that they have to change their psychotherapy to accommodate with MS symptoms. So if you have a memory problem, well, you can't just go to a therapist, have a chat, and then remember what they said and come back a week later. You're not going to remember that. So we give them daily diaries. We have apps that kind of can give them reminders every day. We make checklists for people to take home. So we give them the things that you don't usually receive in psychotherapy that will make sure that their MS symptoms won't get in the way of the effectiveness of the therapy. And I made the mistake in one of my first psychotherapy studies of using something called progressive deep muscle relaxation to help relax an anxious patient. So I had him contract the muscles as hard as he could in his arms and then relax them. And this is a common technique. And when he got to the muscles of his legs, boy, did he have a nasty spasm. So I learned very quickly I have to make a complete inventory of the current symptoms the person with MS has before I'm going to select the proper approach in psychotherapy that will be in sync with the symptoms the person has. So I don't make them frustrated or certainly make them worse. And as I said, and as Dr. Shapiro has implied before, we need a lot more evidence in the evidence base. We have much more of a practice base currently than an evidence base. So, and recent studies are, kind of applying psychotherapy to many MS symptoms. We just finished a CBT study that sought to change pain perception in people with MS, getting them to think differently about their pain so they're not as upset about it, doesn't interfere in their lives as much. We haven't done the data analysis. I can give you a progress report in the future. So I want to take a little bit of time to ask you, how many of you would like a quick lesson that might reduce your feelings of distress and make you more relaxed? I can kind of teach you that right now. How many? Okay. This is going to be a brief lesson in meditation. How many of you have ever meditated? Okay, great. A lot of you have. So there are many types of meditation. We have to select the right type for the persons with who has MS, their symptoms. We don't want to use visual-based types if you have visual memory problems. You're not going to be able to visualize it. If you have severe attention and concentration difficulties, we don't want to give you concentration meditation. It will be an exercise in frustration. So after we look at the symptoms, so what I'm going to teach you now is kind of a blend of a variety of meditation types. About 80% of people that I try this with like it. About 20% don't like it. We're not machines, we're human beings, and everybody needs a different approach. So, are you ready for your do I have 5 minutes? Okay. So, I want you all I'm going to instruct you to breathe at times. When you breathe, I want you to breathe in kind of deeply through your nose and out slowly through pursed lips. And make your exhalation twice as long as your inhalation. And there's a nervous system reason for this that I won't go into now. But again, don't do anything I tell you to do if it's going to make you uncomfortable, or if you have COPD and breathing deeply will exacerbate. So again, don't do anything I tell you to do if it's going to make you uncomfortable. So, you ready to begin? Okay. I'd like you all to get as comfortable as you can in the chair that you're sitting in. Okay. Might want to stretch your muscles a little bit, as long as it's not going to induce a spasm. And close your eyes. And I'd like you to begin by taking 3 slow, deep breaths in the way that I described. Slowly, in through your nose, out more slowly through pursed lips. And then just allow yourself to breathe at whatever is a comfortable rate, a comfortable rhythm. And I'd like you to begin by trying to focus on relaxing the muscles in your forehead and scalp. Picture the muscles in your forehead and scalp becoming smooth as you allow the muscles to relax there. Allow the relaxation to flow down into the muscles of your eyelids. As you allow the muscles in your eyelids to relax more and more, it will almost feel as if they are getting heavier and heavier, more and more relaxed. Allow the relaxation to flow down into the muscles of your jaw hanging a little more limp, a little more loose, a little more relaxed. Allow the relaxation to drift down into your upper back and your shoulders, becoming a little bit more relaxed. Take another long, deep breath in the way we described to stretch the diaphragm, the muscles of the abdomen. And then continue focusing on relaxing the muscles in your lower body and your legs to the best that you can. And as you're allowing the muscles in your body to relax just a bit more, notice your breathing cycle. Notice the natural relaxation that occurs in the body each time we begin to exhale. Our muscles let go, our body relaxes just a little bit more. So I'd like you to, while you're keeping your muscles relaxed, focus on your breathing cycle. Every time you exhale, in your mind's eye only, say the word one silently to yourselves each time you exhale. There will be many distractions from keeping your body relaxed, your mind focused on the breathing cycle, saying the word one silently to yourselves each time you exhale. The sound of my voice will distract you, sounds in the room, memories come into your mind, your list of things to do, sounds in the room. Do not be concerned by any distractions. Welcome them. Simply acknowledge them and gently return your attention back to your breathing cycle. Gently return your attention to saying the word one silently to yourselves each time you exhale. I'm going to allow you to practice this silently for 60 seconds. And once again, I would like you to take 3 slow, deep breaths in the way that we described. And now, I'm going to count backwards from 5 to 1. And as I do so, you will allow yourself to feel increasingly refreshed, relaxed, yet alert. 5, 4, 3, eyes open. 2, 1, refreshed, relaxed, yet alert. How many of you felt yourselves able to relax a little bit more with that procedure? Yeah, most of you. Most people can. And if you can't, that's okay, that you just need another approach. So it's important for you to know there are relatively easy approaches that you can learn to help you regulate your anxiety, and much professional help available to help you combat depression, which is so common in MS. I want to thank you all very, very much for participating today and being here, and I will turn the podium back to Dr. Shapiro. Thank you all.